The information presented on this program is not intended to take the place of your personal physician's advice and is not intended to diagnose, treat, cure, or prevent any disease. Discuss this information with your own physician or healthcare provider to determine what is right for you. Welcome to Sanitas at sanitasradio.com, because your health and longevity should not be classified information. And now, here's your host, Mel Fabregas.
Greetings to everyone around the world, and a warm welcome to another edition of Sanitas at sanitasradio.com. I'm your host, Mel Fabregas, and I sincerely thank you for joining me once again. And if this is your first time, please make yourself at home. And to listen to tonight's full interview, a very important interview, just go to sanitasradio.com and subscribe. It's your life. Take control. Did you know that the leading cause of death in the United States is heart disease? Are you interested in knowing how to prevent and even reverse cardiovascular disease without surgery or medication? Tonight's special guest has been doing it for the past 20 years. She has a proven program that also involved enhanced external counterpulsation, EECP. She is the world authority on this treatment. The three most important things the program does are: it heals the arteries and reverses high blood pressure. This reverses the aging process. It grows new arteries, so anywhere there are blockages, you can grow new arteries. And release of stem cells that can heal any cell in the body. Tonight's special guest is Sara Soulati, and her program, the Sara Soulati Health for Life program, is an alternative for angioplasty, stents, bypass surgery, and many medications. And directly from Santa Monica, California, I would like to welcome Sara Soulati. Hello, Sara. Welcome to Sanitas. How are you?
I'm doing great. I'm so happy to be here today with you.
Oh, it's my pleasure. And Sara, you contacted me some time ago, and basically in the past couple of days, I've been overwhelmed by reading what you have done for the past 2 decades. And I cannot wait, as I told you before we started, to shatter the paradigm, because a lot of people who listen to us don't know that the number one cause of death in the United States is heart disease. And some people, when they have some pain, they go to the cardiologist and immediately they're told, we need to put you in the hospital. We need to immediately do a bypass surgery. And people, since they see a white robe, they feel that the authority is there. They don't challenge it, and they don't know there are alternatives. But before we begin, tell us some of your background. Give us your bio, which I usually read, but I'd like to let you do that today.
Sure, I'd love to do that. My background actually is in the medical field because my grandfather was a surgeon. I'm originally from Iran, and my grandfather was a surgeon in Iran, and my father is a surgeon in Iran, and they owned a hospital back home in Iran, and my father still works as a practicing surgeon in Iran. And so I knew that I had to be in the medical field. I knew that that's something that would make my family happy, and it was some type of a stable job to have. Mm-hmm. But it was just really hard because as a young girl, I just didn't really believe in the medicines that that people were taking even as young age, or having surgeries at young age. But I really wanted to be in the medical field, but I couldn't really get my hands around the whole pharmaceutical world of it. But with that, I still decided to go into the nursing program, which I did. I started as a nursing program, but prior to becoming a nurse in 1989, I became a vegan myself. And I have to say that going through the nursing program, knowing that food had such a huge effect to our life and our health, I didn't see that in the program at all. And I was kind of discouraged and really, really kind of depressed going through the nursing program because everything had to do with, here's the medicine, let's do a care plan based on the side effects of the medicine that the medicine can possibly have. And I would sit there and say, well, what about education on food and how we're going to change the lifestyle? And this is the early 90s. And today I'm sure it must be different, and I'm not really sure how different it is in the medical schools or in the nursing schools. But back then, really food was not even something that we discussed or educated ourselves with when it came to healing the person from the disease. So after that nursing program, I decided to maybe go into the physician assistant program, thinking that maybe that would be a better way, because I really was not enjoying just to being a nurse to just passing medicine around and doing, illness medicine. And while I was getting involved in the physician program in 1996, I found EECP, which stands for Enhanced External Counterpulsation. And it was just the best fit for me, because it gave me the opportunity to really not only study the patient through this treatment and what this treatment did, but I got to stand next to the patient for a whole entire hour, finding out exactly what they were doing in their life and what are they doing every day that was actually causing the hypertension or the diabetes or the elevated heart rate. So I got to really get to study and see patients and the reasons why they were having these problems. Not just you have this problem, let's take the medicine, but let's really dig in and see why. So I really think of myself as an expert in EECP because it's been 20 years, but it's really because the patients and I came together and we learned about the disease and our lifestyles and what they were doing and how they ended up having this problem because of all the years of doing whatever they were doing.
Is heart disease more prevalent in the United States than it is elsewhere?
Well, while I was going to nursing school and physician assistant school, I also decided to get into the medical anthropology field. And at that time, I was so excited because for the first time, I was looking at different cultures and finding out how different cultures did not have certain diseases and when was the first diabetic patient? What year was that? What was the food intake of that person and that whole entire community of people that were diabetic? Or when you're looking at cancer, or when you're looking at heart disease. And then that's when I really realized that, look, I've been a vegan for all this time, not thinking about disease prevention, but studying the different cultures and seeing how disease entered into the culture. It was clear that it had to do with the lifestyle. And the lifestyle that we have here in the West is definitely different than even the lifestyle that we have in other countries. So I definitely can correlate with heart disease being a lifestyle disease.
Put things in perspective. How different is an American, an average American, to, say, an European or somebody from another country?
Well, the thing is that the food itself, the meat, it's even compared to my country or European, the meat itself is such a big part of the diet. Eating animal products is like the staple, is like the center of your meal. If you don't have the meat, then you really don't have the meal. Even in the European culture and the Mediterranean culture, they do have the good fats, and they do eat fats, but they also have a lot of the good fats. And there's just lots of green vegetables surrounded with that. And even for me in my culture, we may have had meat on our dinner plate or for our lunches, but it was very small amount of meat, and around it was a whole bunch of vegetables and spices and herbs that we would combine the meat with. Whereas here, what I noticed, it was just the meat was the larger portion of
yes,
and the vegetables were a smaller portion. And then we wonder, well, look at the heart disease that we're looking at, or diabetes that we're looking at, and the carbohydrates that we consume here in the West are just so much more than we consume in other parts of the world.
Yes, and we'll talk about that. I'm very interested in discussing this because people are confused. They think that all carbohydrates are bad, but you have the white ones, you have the brown ones. But also in the United States, I tend to see, I'm not a doctor, but I tend to see the pyramid is inverted. For example, here we're told, have a small breakfast, have a mid-sized lunch, and have a big dinner. Shouldn't the opposite be true?
It's so funny because I took the pyramid and I did invert it myself. I totally did that because I realized that all the vegetables, and I put the first thing is I put the vegetables. And it's not so much, it's not so much lunch, dinner, or breakfast. It has to do with what are we consuming during those times of the day? And eating the vegetables and the small amount of vegetables is what the pyramid is really missing. And it's got a lot of carbohydrates in it. So for me, it's such a blessing that I became a vegan at such a young age that I got to really see it for myself. And because we have really high diabetes in my family and heart disease and stroke in my family, and some of my family members that are my age are having problems with, metabolic syndrome, which we'll get into, which is really the factor of, heart disease and stroke is really looking at this metabolic problem that we're having. But the food is really the center. I mean, you can't really address the problem if you're not going to look at what you're putting inside your body every day.
To many, going from meat eater to vegetarian is drastic, but becoming vegan is even more extreme. How and why did that change for you?
Well, it's a really funny story. My mom doesn't like me to talk about this story, but I was in nursing school and dissecting a cat. And at that time, I was eating meat, and I was like 19 years old, and I was dissecting the cat, and we had to put some fire on the cat to separate the skin of the cat to the muscle. And I looked around, and I said, wow, someone's barbecuing. It smells so good. Oh. And then I realized that it was the cat. And then I looked at the cat, and the cat's muscle was very much similar to like a chicken thigh because it was shredded. Like I had to shred the muscle, separate the muscles, and look at the different ligaments in the cat. And I was just saying, wow, it smells like barbecue and it looks like cat. And, and I just said, okay, well, that's weird. And I'm not going to go into that too much further. That night I went home and my mom happened to give me a shredded chicken sandwich. And when I bit into that sandwich, you
thought of the cat.
I saw the cat. I'm like, wait a minute. If it looks like the cat, it smells like the cat, what is really flesh? What are we really talking about? In different cultures, they eat different animals. They eat dogs or cats or whatever they have to based on survival. And I realized that, it's the additives that we add to make the meat flavorful. I mean, the meat itself obviously has no taste to it if you don't add all of the marination and the flavors to it. And that night, it was really hard. I didn't eat the rest of the sandwich, and I happened to have had a book that was done by Paramananda Yogananda. I don't know if you've heard about him.
Sure.
Amazing spiritual teacher. And he had this book that was called Man's Eternal Quest. And it was a 380-page book, and I went to the back of the book, and I looked up cleansing. And in the whole book, it was about 2 pages on cleansing. And as I read that chapter on cleansing, it was just common sense. I mean, as far as what we're going to put inside the body, how we're going to overwork the organs for the purpose of digestion. And it was very simple. It had nothing to do with disease prevention. It was a whole different logical way of just looking at how we take care of our body. And that was enough for me. And at that time, I had just got into the nursing program and then working in the hospital. My first job was working in ICU and CCU. And we would get patients that had had bypass surgery. And the night after bypass, we would bring them steak. And I would look at that and say, well, this person can barely breathe. They just had their chest cracked open. They're short of breath. They can't hardly digest anything. But here we're giving them steak. Then they would get constipated. Then we would have to give them milk and magnesia. So it was just, I was looking at the hospital foods and how they would prepare the patient for surgery and how they would feed the patient while the person is in the hospital for diabetes or high cholesterol or high blood pressure or heart disease or stroke. And I really didn't see the food being a big deal except just low sodium. They would say, well, this person's on a low sodium or a low fluid intake. But what about the type of foods that they were eating? So that was really one day dissecting the cat, going home. My mom giving me the sandwich was a blessing in disguise. And as the years continued and I started to get into more of the field of prevention, I realized that the vegan lifestyle was just beyond just the spiritual part of it for me, but it really had to do with disease prevention and reversal of disease.
I like to, not to use the word dissecting too much, but I like to dissect the progression from meat eater to veganism in a moment. But I've also heard of people who go through cancer and they go through chemo and radiation and the standard of care. And what are they given there at the hospital? A lot of dessert, sugars. And we know that feeds the cancer. Why is nutrition not an important part of the medical industry?
Well, I think that it's not even in the teachings of medical school. I remember speaking to this physician, and he was telling me that in the whole 10 years of medical school, that's only 2 hours of nutrition.
Right.
So it's hard for the doctor, because here you go into an institution, you're going to follow these guidelines, you're going to follow these laws, and by the time you're done, you really believe what you've been studying for 10 years. And my father being in that same way, being a surgeon, being a doctor, my father was originally, before a surgeon, he was a pharmacist. That's what they were taught. And so we're really going into the education process. Until now, I mean, we're talking 10 years ago, 15 years ago, but I think today a lot of doctors are opening up and seeing that the food and the lifestyle are factors. There's no way that we can just put someone on medicine and not talk about the nutrition. But the problem is that they don't have the background. Where did they get that information, or where are they going to get it? Because they're not getting it in medical school. And there's lots of physicians now that are doing their own research and doing their own readings and finding out about how important our lifestyle really is when it comes to prevention and reversing the disease.
Not to get conspiratorial at all, but I have to ask this. Could it be that the food industry and the medical industry are intertwined? In other words, if you have a medical doctor saying, well, you shouldn't be eating canned food because you have all these preservatives there and you have the nitrates and the nitrites that can cause cancer. Is that why they don't talk about it?
Well, for sure, in my lectures, I always bring up the fact how the FDA is the same company, the Food and Drug. And there's the whole thing. I mean, the people that are giving us the medication are also approving the food. So these two things should never be combined. This is all under one umbrella of a company. And I think that is a problem, because no matter what, if I'm profiting off of the medicine, I can't really talk about the things that will prevent me to get the medication. So I do think that that's a problem, having the FDA, which is the Food and Drug Administration, all in one place.
Because if you had to start dividing them, and the Food Administration on the Food and Drug Administration, then you would make food healthier, which means less patients for the medical industry, wouldn't it?
Yes, and that's where the whole entire process is. I mean, and now we're fighting with this whole world of GMO and not labeling. Mm-hmm. And if it's really good for you, like they said, then let's label it. But, they're not really letting the people know what's exactly in the foods, but the problems are occurring due to the foods. And then they've got the answer, which is the medicine, but it's not even the answer. If medication really worked, that would be great. Then we would not have number one cause of death in the United States being heart disease, because it doesn't really work unless we change the lifestyle at the same time.
Now tell us, let's go back to 1996. How did this transition happen? Did you see the light and said to yourself, I must do something about this? And this is when the butterflies started flying in a way?
It really was like that, because I was working in Newport Beach, Hoag Hospital, and while I was going to nursing school, I was working in CCU and ICU, and it just didn't feel good inside, watching patients, and you keep watching this patient, like the patient would come in, had a heart attack, then he would get a stent, and you would think that, okay, you're not going to see this patient because he had the stent and he's good to go. And here it comes again, 5 months later, the patient would come back. And this becomes normal to you, because when you're in the medical field, this is normal. You get high cholesterol, then you have hypertension, then you have blockages of the arteries, then you get the angioplasty, then you get the stent, then you get the bypass. So it all was completely normal. In the medical world, this is what will happen. And for me, I kept seeing the same patient come back with another heart attack or another stent or another bypass. Then they would end up being in heart failure. And it was really uncomfortable for me to be in that type of environment because I felt like I was really doing nothing to help these types of clients. And my friend was working with me at Hoag Hospital, and some entrepreneur, 75-year-old man, was watching EECP, which was coming out of New York. It was actually coming out of Stony Brook University, where they had just finished their clinical trials and they had just gotten EECP FDA cleared in 1995. And so he was thinking it was going to be the biggest thing ever. Could you imagine something that could replace bypass surgery, something that could replace stenting? And Vasomedical, which was the manufacturing company, was also very excited, thinking that here comes a machine that's non-invasive, no negative side effects, that could actually replace something that is really scary, which is bypass surgery. And at that time, this man, his name was Dean Olson, had opened up one clinic with one bed in Newport Beach, and my friend was working there. And she needed to go on vacation, and so she called me. She said, look, nobody knows how to use this machine. I need to go on vacation. Why don't you just come and cover for me, and I'll train you how to do it and how to take care of people on the machine, and I'm going to be gone for like 3 weeks. So during that time, I was still in nursing school, getting ready to go and finish my program and then working at Hoag Hospital. The minute I got into that clinic and I saw this machine and how people were laying down on it and how I had an hour with them, for a whole entire hour, I got to stand next to the machine and talk to the client. It was like a major love affair. I could not believe that I had the opportunity to really get into the patient's mind, their heart, their spirit, to see what was going on, to see how they ended up with diabetes. And what I can say out of everything that I've done is that I've become a really good assessor, someone that I can really take down and sit down and make a really good assessment on when did this happen, what were you doing, what did you eat, how were your thoughts, and dealing with not just the food itself, but the lifestyle of exercise, but then the lifestyle of meditation, the lifestyle of old, habits, spiritual habits, anger, jealousy, everything came through this whole entire process for me as I stood next to the patient. And once we get into and explaining to everybody what the treatments encompass, but we were with the client for 35 hours because the treatments are 1 hour a day. And in 1996, when I started this, I remember my friend leaving because she didn't want to continue doing this line of work with this practice. And the owner of the company came to me and said, well, I need you to work full time because you're the only one that's trained. And I said, okay, well, what's the pension are you in a 401k? Is there like a guarantee? Am I going to have health insurance? Because, working as a nurse, I was going to have a guaranteed job pretty much anywhere. I was going to have, time and a half and pension plans and healthcare benefits. And he said, no, I don't have any of that. What I can tell you is that each month I can tell you if you'll have a job next month because we're brand new in this world. And there's only one other clinic, which was in Stony Brook. And I said, that's it? You could offer me a contract month to month? And he said, yes. And I remember going home thinking, what is my father and mother going to say? Because here I'm like 25 years old and I'm about to pretty much go into a whole different field. But I remember this day very clearly and I had to weigh it out. Do I want to do something that I for sure know that I'm going to have support and going to be taken care of financially? Or do I want to choose something that I believe in already that has no foundation of making sure that I'm going to be okay, financially stable, no stability whatsoever? And I just knew that I couldn't make a decision based on just finances. And I was young enough to have the opportunity to just go with my gut feeling and go towards EECP. And so I pretty much let go of nursing school, let go of physician assistant school, came out of the hospital, and that was 1996, and here we are today, still doing it.
That's incredible. The fact that it was almost an accident. You covered for somebody who went on vacation, and then your life basically turned upside down for the best.
Yes, it was such a blessing.
Now, you started selling the machines. That's how you opened up in the field, right?
Well, I did. In 1996 or about 1997, I worked with patients. I took over that clinic and I worked with patients, and we happened to open up a clinic right next to a really big, well-known preventative type of physician. His name is Dr. Julian Whitaker. And back in 1998, you have to realize that he was so ahead of his time. All his patients were on supplements and taking chelation, and he was dealing with prevention in the 80s. And these were all rich, wealthy people that would fly from all over the United States, and they would come to Newport Beach, stay in the hotel to do the Whitaker Wellness Program. And Dr. Whitaker happened to realize how incredible EECP was, and he started sending patients. So in 1996, the indications for EECP was just people that had chest pain, which is angina. Well, Dr. Whitaker had so many patients that had so many problems that the normal medical world did not help them in the normal care of medicine and surgery, that these patients were paying big money to come to his clinic, and he referred almost everybody to me for EECP. Well, this is where my experience really started, because no one had experience with EECP to begin with chest pain patients, heart patients. And the minute that we opened up our doors, Dr. Whitaker would send me patients that were diabetic, needed amputation, had blockages in their legs, had done bypass graft in their legs. They were renal failure patients, patients with dementia, patients with Alzheimer's, patients with Parkinson's. And so I had no resource anywhere. It's not like I could pick up the phone and say, okay, what do I do when a patient is a diabetic and is on insulin? How do I take care of this patient with EECP? So I really had to sit next to the patient and document everything before and after. And that's where my great experience came with EECP and my knowledge, and really understanding now after 20 years how EECP really addresses the whole entire body and not just the heart type of patient. And that was for about 2 years. I did that until 1998. And it was so hard to get physicians to be excited about EECP. So I thought, well, as I was watching these patients that were 80 years old, 90 years old, coming in walkers, and they would throw away their walker. They would come in with canes. They would not need the cane. They weren't really alert. They started becoming alert. And every time a patient, I would put them on the machine, the next day they were telling me how much energy they had, how they were able to exercise longer. And I kept thinking, wow, this is like a 70-year-old. He's exercising longer. He has more energy. What would happen if I got on the machine? So I called Stony Brook and I said, well, I wanted to get on the machine. What do you guys think? And they said, why would you get on the machine? And I'm thinking, well, everybody's having these great side effects from this treatment. And I'm thinking, and these people are really sick. What if I got on it? What would I feel? So they didn't really think it would be any benefit for me to get on the machine. So I strapped myself on the machine because there was no other technician there that could treat EECP except for me. So I put myself on the machine, and that day I went, and I normally would run my 4 or 5 miles every other day. And I ran my 4 or 5 miles. And I could run, and my legs felt so light, and I felt like my breathing, my heart rate, my recovery time. And I remember that day so clearly, and I had no clue it was EECP, because I was thinking, oh, wow, I'm really in good shape. So I let that go, and I didn't really think much of it until the following day when I ran, and I noticed, wait a minute, how come I'm not like that yesterday? How come I'm not feeling my legs being light? And how come I'm not running as fast as possible like yesterday? So then it clicked to me. I said, no way. It had to be EECP. So I put myself on the bed again and then gave myself an hour treatment and then went back to running. And there it was. There was a massive marked improvement in my exercise duration, in my recovery time, and in my lactic acid. So at that time in my 20s, I picked up the phone. I called every single friend I had. I said, I need you to come get on this machine. I know it's really for sick patients, but something is going on. Something is really big here. And I started putting every single person I had that I knew on the machine. And then I would say, go exercise. I want you to go run and I want you to come back and I want you to tell me if there's anything that was different. Sure enough, even all my friends that were in their 20s all came back and said they were able to exercise longer, better recovery time. So I got really excited and I said, well, since the medical field is not going to be really excited about EECP for heart disease because it's going to take away the bypass and the stent, maybe I can go into the sports field and maybe I could open up the whole world of EECP through sports and bring this awareness through the athletes. So I called the manufacturing company, Vaso Medical, and I told them that I wanted to do EECP for sports. Now you have to realize this is like 1998 and they have only sold maybe 5 or 4 beds in all of the United States. And they haven't even got Medicare approval and they've only been FDA cleared for 2 years and I'm already off labeling. And I said, well, just give me a machine. All I need is a machine and I can open up the doors for sports. So long story short, I ended up going to UCLA. I ended up going to UCLA and I started to treat the US Olympic sprint team. And that's a whole other story of how, there's no coincidence of how I accidentally meet somebody in a grocery store that happens to take me to UCLA to meet the US Olympic sprint team. But I had the machine under the bleachers at UCLA and I started to treat all of the 100 gold medalists, Otto Bolden, Maurice Green, Quincy Watts. These were all 100, 200 meter runners for the US team. And that's when I really realized that even an athlete on that level could make a huge impact with their exercise using EECP. I did that for about 6-7 months. And while I was doing that, I really was missing the patient care. So I called back the manufacturer. I said, well, let me also sell the medical equipment for you because no one is buying these machines. And at the end of the day, if the physicians don't buy the machines, then patients are not going to be able to get on the machines. And that was really my motivation, is to get people on this device so they can have a choice. So the manufacturer allowed me to work for them, not just doing the sports study, but I also worked for them selling the medical equipment. And I sold the first medical equipment for EECP for Vaso Medical in 1998. And I sold it to the Pritikin Wellness Institute when they were here in Santa Monica. And I was very excited about that because it was the first EECP machine that was being placed pretty much in the West Coast outside of the one that I worked in Newport Beach. And from there, I met a very rich businessman that said to me, well, stop selling machines. Don't you want to come and work and open up these clinics all around Southern California and you can come work for me? And so I didn't really understand the difference, the wording, work for me or work with me. Now I know that those are 2 different types of words.
Yeah.
So I worked with him and I worked for him and I opened up 10 centers in all of Southern California in all of the rich, affluent areas from Oceanside all the way to South Pasadena to Laguna Beach to West Los Angeles. We had these standalone EECP centers. And during the time when I was working in the field, I met my first cardiologist, which was Dr. Franklin L. Murphy. And his father was a chancellor of UCLA. And his patient came to me and got on the machine and had such a remarkable improvement with his cardiac condition that I called Dr. Murphy to talk to him about how his patient needed to get off some medicine because his blood pressure was getting lower and I needed the doctor to examine the patient. And from that day, Dr. Murphy and I became incredible friends. And finally, I had a cardiologist that believed in EECP that would actually, send patients, which was very rare in 1998 to have a cardiologist refer a patient to EECP. It just was not happening. So through these clinics
It sounds kind of counterproductive for a cardiologist to be, I hate to say this, but sending his revenue stream somewhere else.
And that's where, when I was selling the beds door to door to every cardiologist, I pretty much went to every cardiologist all the way from Scripps down all the way up to north of LA, which is pretty much the Valley and the Ventura and North Valley area. And every time I would sit down with a cardiologist, he would say to me, well, I can just stent them, or they could just go for a bypass. Why would I want to buy a machine? And the machines back then were $250,000. And he would say, why would I want to buy a machine for $250,000, have the patient come in every day when I can just stent them? And there was so much more revenue in stents. So I had to change my game. I had to go back into the doctor's office and say, well, those patients that you can't stent, those patients that you can't have any more bypass or they can't have any more medicine and they're inoperable patients and they're having chest pain. This is what EECP is for. Because if I was going to have a conversation with the doctor about choosing EECP before a stent or before bypass,
not going to happen.
That was not going to happen. And still, even with that change of saying, well, here are the patients that you can't do anything about. They have small vessel disease. You can't do the stent, or they can't have the bypass because of their diabetes or their comorbid condition. They were like, well, we don't have that many patients because we could always medicate them or we could always do more stents. And that's why I was so excited when we opened up these clinics in Southern California. I said, okay, well, here we go. We became partners. We opened up these 10 centers. We had Dr. Murphy, that was the doctor for these clinics. Still, we would advertise all over the, magazines and radios. Patients would come in. They would qualify for EECP. I would pick up the phone, call the doctor and say, I have your patient here. They want to do EECP. Will you approve it? And they would say, well, what is EECP? And I would have to explain what it is, send them literature. After that, they would say, no, the patient doesn't need EECP. And the funny thing was, for about 2 to 3 years, they would say no to EECP when they didn't even know what it was. And so I really felt discouraged because my whole motivation was that I wanted people to at least have a choice and an option before having another stent or before they would crack their chest open for their sternum for bypass and take the vein from the leg. I mean, it's a pretty big deal to have bypass procedure done. And I just wanted the people to have an option and have their doctor be open-minded that they would at least give the patient a try. Because obviously, if EECP doesn't work, you could always do the bypass. And I just wanted that to be the option. And I realized that even when we opened up these 10 centers and we flooded the market with advertisement to bring the awareness to the people, we were getting our doors were getting closed on our face because the doctors would just say no. So once the doctors of the patient said no, then there was nothing else that we could do. So the patient would not get the benefit from the treatment.
That's incredible. And I like to learn what makes things tick. And correct me if I'm wrong, but am I seeing here a correlation between oxygenation and the absorption of oxygen that is not there before the treatment via the EECP? Am I right?
It's exactly about the oxidation, the oxygen that is being delivered through the blood flow, through the treatment. And if we want to get into the exact mechanism of EECP, let's talk about exactly,
Sure.
What it is and where it came from. It's such an amazing treatment. It started in Harvard in the 50s. People are constantly telling me, how could this be around this long and I don't even know about it?
Right.
And this was before we had the technology to do bypass right away. I mean, you have to realize in the 50s, people were having heart attacks and the bypass team wasn't available, ready to go the minute the patient was coming into the emergency room. We didn't have blood thinning mechanism to thin out the blood to get the blood up to the heart. So they created external counterpulsation, which was really a circulation device. And if you could imagine someone laying on a bed with steel casings in their lower extremities where water would go through the steel casing, and through the water, it was pushing the blood from the lower extremities back into the coronary arteries of the heart. And this was done in the 1950s, and there's these crazy pictures of EECP in its first development. And it was really successful because it was actually moving the blood from the lower extremities up to the coronary arteries and filling up the heart with this oxygenated blood. But the problem was that the water was getting everywhere and the technology wasn't advanced enough. So the Chinese picked it up from the late 50s until the early 70s. The Chinese took that device, which was water hydraulic, and changed it into air compression. And that's what we have today. Instead of the water pumping the blood from the lower extremities, we're now having air pumping from the lower extremities, like deflating and inflating to the rhythm of the heart. So the way that the device looks now is that you lie down on a comfortable bed, and there are 3 blood pressure cuffs that are wrapped around your calves, your thighs, and your buttocks. And we have you timed to your heartbeat. So there's a 3-lead EKG that's being done. And to the rhythm of the client, whoever it is that's laying on the bed, these blood pressure cuffs start to squeeze the blood from the lower legs and start to move the blood throughout the whole entire body. And so that's when, in the early 70s, it got its first FDA clearance in America, which was for cardiogenic shock and acute MI. So when you were having a heart attack in the 70s, this was actually in the emergency room. You would come into the emergency room, they would put you on, they used to call it cardio assist, assisting the heart, technically, and they would put you on this EECP device, and then they would call the bypass team and get the OR ready, and that would be like a couple of hours. But meanwhile, your heart was being saved because we were pumping blood to the heart. And they didn't realize at that time, because I remember talking to a lot of physicians, and they would say, we remember this in the 70s. We remember using this for acute MI and people that were having heart attacks. But they didn't realize that when you lay the person down and if you leave them on the machine for an hour, for X amount of days, for X amount of weeks, our body actually starts growing collaterals due to this blood flow that's being circulated with the device. So people were just getting on it, and then they were just taking them off, and they would get into bypass surgery. When I got my hands on the literature from China, that's when I saw that the Chinese, from 1960s until the 1980s, they were treating everything with EECP. From Alzheimer's to dementia, all the things that I was treating people from 1996, I was able to see that the Chinese were already doing this 10 years, 15 years ahead of us. And not only that, but they also had their swimmers on this device, and they were really dominant. The women's swim team was really dominant during this time, and they were all using EECP for cardiovascular fitness. But it was about a 5-page article that was coming out of China that was using EECP for so many other things other than just heart disease. So that's really the history. It started in the 50s. It went to China. It got perfected. And it wasn't until the early 1990s when Stony Brook, with an amazing scientist, Dr. John Huey, started to look at EECP and trying to understand what were the Chinese doing and why was EECP working. And so he also worked for Stony Brook University, and Stony Brook and Vaso Medical, the manufacturing company, teamed up together to do the first study in the early 90s. And they took patients And you have to realize that no doctor is really wanting to do a study on a patient before a stent or before a bypass with EECP. They really weren't going to get support. Could you imagine if I said to a doctor, well, here I have a device that possibly is going to take away angioplasty?
Well, this reminds me of, in a different way, cancer patients that go to Dr. Brzezinski. He cannot see them unless they have already gone through standard of care. And unfortunately, a lot of times you cannot reverse their condition.
Yes. Oh, I'm a big fan of him. Oh, he's amazing. He's amazing.
Mm-hmm.
It's exactly like that. And so Vaso Medical knew that they weren't going to get supports, clinical trials. So they said, all right, we're going to take patients that are end stage. And so they took a group of patients that had had multiple stents, had had bypass surgery, they have had heart attacks, and they were having chest pain with minimal activity. And this is really important because it's not that they were having chest pain because they were running for an hour. They were having chest pain when they were bending to tie their shoe. They were having chest pain while sitting and eating dinner. And these are called class 3 angina. There are 4 different kinds of classifications of angina. And this is the Canadian classification. And class 3 and 4 are pretty much people that are having chest pain with minimal to no activity. So this is the group of people that did the original clinical trials for EECP. After 35 days, they did it for 1 hour a day, 5 days a week, for 35 days. They had EECP treatments in 2 different universities. And each of those clients, before they started, they had done a stress test. And so they could see how far they were able to walk and how much blood were they getting up to their heart, because they could see ischemia, lack of blood to the heart. And they knew when the patient was getting chest pain. And so they did the 35 hours of EECP. And then after that, they did the same test again. And 85% had an improvement of their chest pain and exercise duration. And the thing about it was that these were end stage patients only getting 35 hours. So I'm thinking to myself when I read this study, because this was back in 1998 when the study came out, and I was thinking to myself, wow, these are end stage patients. These are patients that have already had the heart attack, have had the stent, have had the bypass, or on maximum medication. They have chest pain with minimal activity, and they only had 35 hours of EECP, and they had an 85% improvement. What if they did 90 treatments? What if we had patients before the stent? What if we had patients before the bypass? I mean, that's just logic, right? I mean, I don't have to go really to medical school to realize that if someone is really, really sick and has an 80% improvement, what about if we do it for prevention?
Right.
So that's where so the study was done, and that's when, it was FDA cleared, but Medicare turned down EECP for coverage. CMS turned down EECP for coverage in 1998. And this was heartbreaking because we were watching how EECP was helping and changing so many people's lives without any issues of surgery or side effects of medication. And the CMS came back and said, well, we want this to be published in journals. It's not good enough. You had it in a small publication, but we want major journals to publish this, such as American Heart Association or, cardiovascular magazines or, big time journals. And the problem was that the big journals were not going to publish this.
Yeah, peer-reviewed, sure.
And so we were stuck. We were stuck from 1998 until the end of July of 1999. Vaso Medical was running around trying to get this published in some kind of journal so the CMS could approve EECP because they had turned it down. And there was a great man by the name of Wally Hazelton. He's passed away now, but he sat on the board of Vasomedical. And when CMS turned down the coverage for EECP, he was very good friends with Ted Kennedy. And they had gone to war together. And so Wally Hazelton called Ted Kennedy. And I have this great interview with Wally before he passed, just telling the story of how he made the call and he asked Ted to please push this through. And it was really a favor. This whole thing is because of Wally Hazelton that this got approved. And there was a man by the name of Grant Bagley, which was the head of CMS, and he's the one that turned it down. He was, I think, pretty much upset because he had to be forced to approve EECP. So he decided to approve EECP, but he gave it the hardest indications that I've ever seen in the field when it comes to something that is no side effect and totally non-invasive. And in 1999, CMS did approve EECP, but the indications were as following. You've had to have had maximum surgery. You have had to have had all the stent and bypass you could possibly have. You have to be on maximum medication. And you have to have chest pain that's class 3 and 4, meaning chest pain with minimal activity. And you could only have it for 35 treatments in your whole life. And the only people that can prescribe it to get reimbursed by Medicare is a thoracic surgeon or a cardiologist. So pretty much in 1999, my heart was broken because it's going to be really hard to get anybody to qualify anyone for EECP if that's the criteria, because in the world of cardiology, it just depends on what kind of doctor you have. Some doctors do 10 stents. Some doctors do 15 stents. People do bypass all the time, multiple times. So EECP was just never going to be a choice for the patient until they became end of stage. And that's only if the doctor knew a facility to send the patient to or even knew about EECP.
It's not only the doctors, but the hospital fees, the surgery room, all that stuff. And if I didn't know any better, Sara, I would think that that person probably was under the influence of a lobbyist saying, if you're going to pass this, you will pass this, but you're going to make sure that our revenue is guaranteed. When all else fails, that's when you allow this to proceed.
It's exactly what happened. And I think at that point, I wish that Vasomedical would have fought that approval instead of, because they could have fought it and gone back and said, no, we don't want this approval. But they thought, well, you know what? They were in the business of selling machines. And so they needed Medicare's approval in order to be able to sell these machines. These machines were $250,000 for each machine, which is still nothing compared to bypass surgery and how much hospitalization it's costing for bypass surgery. I mean, it's one of the biggest costs to healthcare today is bypass surgery. And here's something that's just so simple. And the reimbursement from Medicare is about $5,000 for 35 hours. So a doctor is just not excited to buy a machine for $250,000 and then have the patient come into his office for 7.5 weeks and then train someone to do the treatment where he can just stent them and be in and out of the hospital in 2 hours. So Vasomedical took the ruling and thought, well, let's just take the ruling and hopefully down the line it will change. And hopefully we can get it to change. Well, still today, since 1999 till now, it has not changed.
So that disclaimer still exists, just the way you read it.
That's exactly what. Now, when you look at the billable code, because, every procedure has a code. When you look at the billable code for EECP, it's 413.9, which basically says other unspecified angina. And the word angina means someone not getting blood to their heart due to blockages of the arteries or spasming of the arteries or small vessel disease. It's just angina means lack of blood to the heart. Now, that's the billing code for EECP. But when you read the guidelines for Medicare, they have those stipulations that I have just mentioned. And at the end, it's still left to the discretion of a cardiologist. So meaning that if you came in and you wanted this and you needed it and your doctor said, well, you could probably have another stent, but I'm going to use EECP. That's still a choice of the cardiologist. It's just very rare back then. It's better today because of the work that we've done here in Los Angeles, but it's just very rare that a doctor is going to recommend EECP if he can do another stent.
I can see the logic behind that. If I play in devil's advocate, of course, how did Stony Brook University, being academia, usually academia survives in a lot of grants and financing from sponsorships from companies and government. How did they do it?
It was I believe it was Vasomedical, and that's what this Vasomedical actually gave the funding to the universities to do it, but still the universities chose to use the criteria of that end-stage patient. Not knowing that just because they studied end stage, that it would only be approved for end stage. Because if it could help someone, the whole theory with EECP, which we can really get into of exactly how it works, the process with EECP has to do with angiogenesis. It has to do with creating collateralization. And that's why they call EECP a natural bypass. So like we mentioned that here you are, you get to lay down on a comfortable bed and 3 blood pressure cuffs are wrapped around the calves, the thighs, and the buttocks, and to the rhythm of your heart when the heart is at rest. Now that's a really big deal because it's not pumping the blood during systole, which is the working phase of the heart. It's pumping the blood during diastole. That's when the heart is resting. So it pumps the blood during diastole and it moves all the blood into the coronary arteries. And when the heart goes to pump again during systole, it realizes that all the blood is already up to the heart. So it decreases the workload of the heart. It decreases the blood pressure, but there is an increased shear force of blood going from the lower extremities throughout the whole entire arterial system. So what's actually happening is that, and it's not a very small pressure. You start with pressure 1 and you end up with pressure 4. And it's a lot of pressure that's in the lower extremities, just like blood pressure cuffs, deflating and inflating cuffs that are wrapped around the 3 largest muscles. And it's moving the blood from the legs all the way through the whole entire arterial system, not just the heart, but obviously the arteries are the highway of blood flow through our whole entire body. And that's how we get this oxygenated blood being delivered. And EECP, by pumping during diastole, it actually starts to put a lot of pressure and starts to put a lot of blood flow in the endothelium, and it starts to pressurize the endothelium to start secreting VEGF, which we call vascular endothelium growth factors. So it pushes this shear stress in the endothelium. And if anybody knows anything about how amazing the endothelium is really the root of everything. If you want to know how old you are, we check your blood pressure, which is talking about how stiff and hard are your arteries. Well, by pumping this blood through the endothelium, we've got nitric oxide coming out, which is a vasodilator. We've got all these hormones that are coming through the artery walls and secreting, such as I mentioned, VEGF. And so this constant blood flow pushing and putting this stress in the endothelium, we're actually helping grow the vascular endothelium growth factor, which starts to develop the collaterals, and it starts to bypass the blocked artery. So they've actually seen these collateralizations that have occurred, patients that have had 1 vessel disease, 2 vessel disease, 3 vessel disease. They had the stent, they've had the bypass closed, the grafts of the bypass closed, they end up with the blockage, and then they put them on EECP, and through angiography And through PET scans, they actually saw collateralization after the 35 hours of EECP. And not only did they see it, but the patient has been feeling it since day one. Less chest pain or no chest pain, no shortness of breath, and able to exercise longer because we're really growing new arteries to bypass the blocked artery. Now, that was clear. That's what the studies show. That's why it's FDA cleared. That's why it's covered by Medicare for reimbursement, because the whole thing is based on developing these new collaterals. But obviously, if we're doing it in the heart, we're doing it everywhere. If we're improving collateralization for the cardiac patient, we're improving collateralization for a stroke patient. If the blood is going through the whole entire arterial system, what else is happening for a diabetic or a renal failure patient or a patient that has poor eyesight or a patient that has dementia? And that's where my work with EECP is very different from everyone else's, because I was standing next to the patient, not only concerned about their heart disease, but I was documenting and making daily assessments on what else was the patient having, experience with EECP, what other diseases did they have, and was EECP having an effect on that? And it really was. EECP was really having an effect on the total function of the cardiovascular system, and all the organs that were really involved with EECP were getting the benefit from it at the same time.
What about beyond the cardiovascular system, other organs? Say, nephrologists, they deal with the kidneys. How about kidneys? How about liver? How about lungs?
I will tell you about my experience, and everything that I speak about is just the experience that me and my clients have had in the last 20 years. Patients come in for heart disease, but their creatinine levels are elevated. They're borderline getting ready to go on dialysis. And so this is all, nobody knew that we were going to improve the function of the kidneys, but they were coming in and they went back to the nephrologist, and now their creatinine levels have lowered. And so what are we really doing? We're perfusing the blood flow to every single organ. And I talk about EECP really having three major effects of the body. But when you talk about these three major effects, they're really deep and they're really, really big deal as far as what it's doing. So number one, if you have blockages of the arteries, EECP will grow collaterals. We've seen it in the lower extremities of the patient that have blockages of their legs in their lower extremities. We've seen it with the heart patient. We've treated patients that have had a stroke that could not speak from the stroke, could not walk from the stroke, could not swallow from the stroke. And I've seen clients, and they're on the YouTube giving testimonials of how they weren't speaking before EECP, how the blood was obviously going up to the all the way from the coronary arteries to the carotid artery, all the way up to the brain. And we're just moving that blood to an area that is ischemic. So when someone has a heart attack, not only is EECP growing new arteries, it's actually repairing the heart muscle that was dead before. Nowhere in time did they ever think that when you have a heart muscle that is dead, you can actually rejuvenate it and get it to be no longer ischemic. Well, we did cardiolite testing before and after, which would show ischemia of the heart. And then after EECP, the ischemia of the heart was gone. So collateralization, not only growing these new arteries, but we're talking about the heart function itself, which that's what heart failure is. It's like the biggest industry is heart failure, because there are no treatments that are FDA cleared for heart failure. When your heart doesn't pump, you get full of fluid. You go to the hospital, they give you diuretic, they take the fluid off, you come home, then you end up with more fluid, you go back to the hospital. It's one of the largest revenue sources as far as the healthcare system that it puts a lot of pressure on is heart failure. Well, EECP has been FDA cleared for heart failure since 2002, but still today, Medicare does not cover heart failure for reimbursement, even though it's FDA cleared. So I'm giving the example of not only are we growing new arteries with EECP, but we're actually having a direct effect on every single organ. And what they know now with EECP is that it stimulates stem cells to come out of the bone marrow into the circulatory system and helping rejuvenate and repair the organs, such as kidney patients, such as renal failure patients, such as diabetics. When I started taking patients that were diabetic, I had no understanding of what EECP was going to do, but we started to put them on EECP. The next day, their blood sugar was lower, and as the treatments continued, the blood sugar was lower, and we noticed that we had to call their doctor, we had to adjust their insulin medication and their oral medication, and what was occurring was that the pancreas was getting functional again. And I was noticing that people's pancreas that wasn't producing insulin before was able to produce insulin now. And that's when we realized that, wait a minute, these stem cells are repairing the organ itself, and these organs are getting back to be functional. We knew that it was doing it for the heart. We knew that if someone's heart, which is called an ejection fraction, which tells us how strong is the heart pumping, people would come in and their ejection fraction, which is EF, would be in the 30s, in the 40s, in the 20s. And after 35 hours, we would do another echo, and we would see that their EF would go up to 50 and 60. And that's what heart failure is. If you're below 20, you're in heart failure. Obviously, if you're 30 and in borderline 40, you're in heart failure. But you're really getting into a transplant waiting list when you're in the 20s. Well, we had the opportunity to treat a lot of patients that were waiting for transplant. And during the time when they were waiting for transplant, you have to realize these kinds of people are really suffering because their heart is pumping at 6%, 7%, 10%, and they can't do anything. At any time, they could just die. They need a new heart.
But they're almost dead.
They're hanging on by such a tiny little thing, and we would put them on EECP, and we would circulate that blood up to the heart, and we would get that oxygenated blood to the heart. And these people did not have blockages of the arteries because they didn't have coronary disease. They just had heart failure, because you can have heart failure and blockages of the arteries, or you can just have heart failure without blockages of the arteries. And we've had a whole bunch of patients. Very recently, last year, we had a patient that came off the waiting list from Scripps La Jolla Hospital and said...
Oh, hold it right there. Before you give us that testimonial, why don't you give us that testimonial when we come back, because we have to separate both segments. But the way I'm seeing this, Sara, this is David versus Goliath. Mm-hmm. And I'm hoping that David wins in the end. And when we come back, I want you to tell us more. Also, what people can do to improve their lives. Give us a synopsis of the 35 days. How can people learn more about this, Sara, that this is available to them? And you have proven to me today that this is concerted. This is a concerted effort to keep this information from the public, because doing what I do, I think I have my finger on the pulse in alternative practitioners, information. But it wasn't until you came to me that I realized, wait a second, I'd never heard of this door. Let me open it. So I'm glad you're here today. Tell us, how can people learn more about your services, the work that you do, and so on?
They can go on the website. It's globalcardiocare.com. We have a YouTube channel. I think the YouTube channel is so amazing because these are just from people's testimonials. There's over 70 patients giving their testimonials from all types of diseases, not just end-stage cardiovascular disease. Just go to YouTube and punch in Global Cardio Care, and people can call and come in and try the treatment out for free. I really open the doors to people and allow them to come in and get a free session so they can see for themselves, because it is that important to me.
I saw some of those testimonials and I just could not believe it, that this information is not more prevalent out there. I can see why cardiologists, we have the number one industry in the world is oil, followed by cancer. And I wouldn't doubt if cardiologists and everything that's related to heart disease is also up in the top 10 industries in the world. So I can see how this can threaten them. But folks, you're listening to this. You're very, very lucky to be here with Sara Soulati today. This is Mel Fabregas, and we'll be right back with much more. Don't go anywhere. Thank you for listening to the first segment of this very important Sanitas interview. If you enjoyed it and wish to listen to the rest, go to sanitasradio.com, click on members or subscribe, or tell someone else who will enjoy this and all our radio programs. If you are listening on YouTube, like, subscribe, and share it. Don't forget to visit the Sanitas store, where you can purchase pure organic sulfur, detoxified iodine, supplements, our USB drive with all our shows, gift certificates, rebounders, and much more. Now, join me in the Sanitas member section to enjoy the rest. Thank you.